Brilliant. Okay, we're almost there. I think we're waiting for a few more to enter and we get started. Okay. Right, so we're going to share the screen, and Jason, just let me know if my screen's working.
Yep, I can see it. Yep.
So just to making sure that everyone's on mute. That's great. Thank you so much. Brilliant. And camera stand off, preferably for everyone as well. Thank you. Great. Let's get started, guys. So just hello, everyone. Once again, my name is Rushabh Savla. I'm one of the directors at R&D Physio. I'm joined today with Jaissal Patel, who is a shoulder specialist in our Northwood clinic. And no introductions needed here for Mr. Rupen Dattani, who is a shoulder consultant. Fantastic, let's get started. So Jaissal, let's get some introductions done. Mr. Rupen Dattani is a shoulder and elbow surgeon. He works at, privately at Total Orthopaedics and then also in the NHS. Myself, I am a shoulder specialist. I've been doing physio work and most of it in shoulders, and Jaissal's the same. Without further ado, let's get started. Jaissal?
Cool, I hope you can all hear me. What we're going to be doing is kind of going over kind of a frozen shoulder 101. So it's a long-term debilitating condition defined as something which is of uncertain etiology. So something that we're not still learning about in terms of the cause of it. It's characterized by restriction in both active and passive shoulder motion that often occurs in the absence of a known intrinsic disorder. So essentially it can occur when there's no internal issue with the shoulder that's known. First described over 150 years ago. That being said, it's been around for quite some time, but something that's often quite misdiagnosed and missed and often goes under the radar. In terms of who it affects around 5% of the population, but it's a high incidence and prevalence in diabetic patients. So around 20% of diabetic people will at some point suffer with a frozen shoulder, and we'll go into why that happens later. Unfortunately, it does affect ladies a bit more than males, with a 4-to-1 ratio, and there's an increased finding that there's an increased dominant incidence in the non-dominant shoulder, and it appears to affect those in their 4th to 5th decade of life as well.
Brilliant.
So in terms of the frozen shoulder stuff, there's 2 types. So what we talk about, the unknown intrinsic disorder in a shoulder which already exists. So people with diabetes, those with hypothyroidism, those with cardiovascular disease, and also stroke, which we think that there may be some inflammation pathway that plays a part in it. And then also secondary frozen shoulder. So I'm going to throw the floor over to Mr. Dattani, who sees quite a lot of these particular types. Mr. Dattani, what do you find in terms of those who have had surgery, but also those who've had an accident and develop a secondary frozen shoulder?
Yeah, thanks, Jeff. So in terms of post-surgical, it's thought that about 5% of people who undergo sort of shoulder surgery of any kind, if it's a keyhole surgery or to repair the labrum, then about 5% of those will probably get a frozen shoulder. And that's why I tend to consent patients for any kind of shoulder arthroscopy procedures. I said there's about 5% chance of getting a frozen shoulder. And that's a sort of post sort of surgical, because you've had an inflammatory response and the patient's sort of immune system has reacted to that particular insult to the body, and that's what's caused the post-surgical frozen shoulder. In terms of post-traumatic frozen shoulder, again, that's very common. It's not necessarily after a fracture, but it's after an injury. Someone's had a fall, either landed directly onto their shoulder or onto their back, or just wrenched their shoulder, and they're fine at that time. And over a period of the next 2 to 3 months have developed a frozen shoulder. We sometimes also see these after sort of skiing injuries where people have had a fall and have developed, sustained what's called a greater tuberosity fracture, which is not always obvious on an X-ray, but is subsequently picked up on either a CT or an MRI scan. And the treatment for that is non-operative, where they go into a sling, but it's quite often, some of these patients will then go on to develop a frozen shoulder. So it's another sort of secondary cause of a frozen shoulder.
Brilliant. I think Jaisal's got a really good understanding of this, but as you can see, a lot of it is actually quite complex. Jaisal, do you want to sort of go through why it's so complex to diagnose a frozen shoulder? And then Rupen, I guess people come to you and tell you, well, what?
Oh, Rush, I think your internet's frozen, has it?
Yeah, I think Rush is sort of frozen, but just, do you want to take this slide?
Yeah, sure. So in terms of frozen shoulder, it's a very, very complex process and it's multifactorial. So there's different aspects which can affect someone getting it. Essentially what happens is there's a chronic low-grade inflammation. So that being said, it's developing over a
So if you have some technical difficulties.
Can you still hear me, Rush?
Sorry about that. I don't know what happened there. Can you see my screen?
I could just see you, not your screen.
Okay, what about now?
No.
Um,
Yeah, there you go. That's great.
Great. Okay, great. So yeah, just again taking us through the complexity of the problem. I think the frustration sometimes is that people will want to find one thing that's wrong with their shoulder. Rupen, what is it that you find?
So quite often people will come to me when the shoulder's sort of very painful and stiff, and quite often I get asked the question, why do you think I've got a frozen shoulder? And what I tend to say is we don't really know. We don't quite understand why people get frozen shoulder. I know we went through sort of the primary and secondary frozen shoulders, but if you look at the pathophysiology as to why people develop it, is now thought that most people who develop it have a low-grade inflammation. And that's why people with diabetes, thyroid disorders, cardiovascular problems, are more prone to it, because it's thought that these conditions are pro-inflammatory, where people have a low-grade inflammation going on, and maybe that's why they're more prone to getting a frozen shoulder. And what happens is when you have low-grade inflammation, you produce these sort of cytokines, such as like TGF, beta, and so forth. And what that does is causes these normal sort of cells, the fibroblasts, to differentiate into what's called myofibroblasts, and you get then what's called type 3 collagen. Normally our collagen is type 1 collagen, but you get type 3 collagen. And it's interesting, it's the same kind of collagen that you see in people who've got Dupuytren's contracture, where you may see people who've got contracture, and it's because it's type 3 deposition of collagen there. What's interesting is Dupuytren's contracture is not reversible. So once you've got it, you've got it, whereas frozen shoulder is potentially reversible. And I say potentially because we'll come back to it, but and that's what's thought to happen. So you get low-grade inflammation, which causes sort of the type 3 deposition. And then what happens is that causes fibrosis and capsulitis, thickening of the capsule, which then causes pain. And one of the other reasons you get pain is because it's thought that you get nerve cells, a new type of nerves being formed around that capsule, which then contribute to the pain. So it's a combination of pain and capsulitis, and then you enter this vicious cycle of pain causing stiffness causing further pain, and then you eventually end up with in the frozen stage of a frozen shoulder. So as you can see from this pathway, I know it's quite a busy sort of diagram, but we're showing is that we don't quite know what causes, but there's thought to be many sort of triggers where you have an unknown trigger or potential trauma trigger, you get the pro-inflammatory cascade, which then causes capsulitis.
Yeah. So one of the things we obviously have seen is that you have your healthy shoulder, your early frozen shoulder, and then your late frozen shoulder. Just from your understanding, at what stage do you find that sort of the change can be seen, either on an X-ray, MRI, or ultrasound? When are you noticing sort of the changes happening, and at what stage should you intervene?
So that's a really good question. So in terms of the diagnosis, when someone's in the early stages of frozen shoulder, that can be quite difficult to diagnose, because they have pain that's very typical of what we might call impingement or rotator cuff pain, where there is pain, but there's also some restriction in movement. So when you're examining them, they can sort of get to about there, and you can't push them any further. And you think, maybe are they impinging? Is it just rotator cuff associated pain? This is in the very early stages. And quite often what they'll have is they'll either have a trial of therapy or steroid injection into the bursa, so come back a few weeks later, and you realize at that point, so that's why the injection hasn't quite worked.
Yeah.
Where in the later stages of frozen shoulder, it's very obvious. They have the classic symptoms of pain, especially pain at night, and quite a lot of stiffness. And then at that point, it's quite an easy diagnosis. But it's interesting to see in terms of this diagram as to what's really happening, because you've got normal synovial fluid that's sort of encases the ball and socket joint, and then you get this cytokine secretion which we spoke about earlier, with inflammatory cells going in there, and that starts causing the normal collagen to change from type 1 to type 3 collagen, and that type 3 collagen then causes fibrosis, and then you get the 3 collagen then causing the stiffness as a result, and you get capsular thickening. You can see in that bottom diagram, you get the axillary recess volume reduces. So for me, this is a clinical diagnosis, but as I said, in the early stages, it can be quite tricky to see if is someone developing a frozen shoulder, or are they just got the signs of sort of rotator cuff disease.
Yeah. So one of the things I find, obviously, with frozen shoulders, essentially, is that there is a very sort of a very typical presentation that will come in with, for the inability to sort of externally rotate, so being able to sort of not be able to get that hand out, sort of into that external rotation position. It's come on all of a sudden, or it's come on with trauma. Again, we went through this earlier, but it can be either or. The other thing is also it's quite painful at night. It's really painful sleeping on it. It's really painful pushing off on it, waking up in the morning with it. So it's really, really painful. And the most important thing is actually just restricted how you get things done. So for the ladies, doing your bra, for the blokes, tucking their shirt at the back, putting the hand at the back, being able to sort of comb your hair, being able to do all the simple things we take for granted. And I think this is where a good history taking, a good subjective taking by any healthcare professional that you go and see is so important, because this is almost like that detective sheet that we can use to kind of gain the information that we need to make the diagnosis of a frozen shoulder, and then move on to how we're going to help you. The most important thing is that actually you get a restriction of a lot of shoulder movements, not just one. So I know Rupen does this really exceptionally well. So I'm going to move on to the next slide. But a lot of patients come back and tell me, Rush, can I get an ultrasound scan, or can I get an MRI? Now, I would say actually the gold standard is just go for an X-ray. A normal X-ray is good enough to see what's going on in your shoulder, and that's to rule out the arthritis. The ultrasound and MRI is to see whether you have any associated tears. So if you have a muscular tear, if you have anything else that's going on in the shoulder. And with Rupen talking about the recess in both shoulders, so that's a healthy recess that you see in a normal shoulder, and then you can see what's happening in that frozen shoulder stage. Rupen, you've got this as your clinical presentation. Tell me why you use this versus just doing external rotation, because I know we've got a few GPs here on board today, and I've been to a GP myself, and I've actually watched a GP do a shoulder examination for one of my relatives, and I was shocked to see that they don't necessarily perform all of them, primarily because we've just been taught that if you don't have external rotation, that's a frozen shoulder for sure, and if you have external rotation, that's a rotator cuff tear.
Yeah, no, thanks, Rush. So I think what this diagram helps to explain is which structures are affected and cause which restriction in range of motion. So classically, what we're taught is the lack of external rotation. And if you had to do one test, I would say that it would be the test to do, right? because you just got to compare your external rotation compared to the other side. But one thing I would suggest, and I think we will show the video later, is probably do this passively, because quite often if you get people to say, can you externally rotate, and especially during these times where we're doing quite a lot of video consultations, you get people doing sort of all sorts of things like this, and it's quite difficult to get them to externally rotate. If you've got a patient in front of you, this is one movement I do get them, and I just hold their arm and see if I can externally rotate compared to the other side, because sometimes you can be fooled into thinking they've got reasonable external rotation when they don't. But when that external rotation in neutral's gone, that's where your coracohumeral ligament has been affected. And then if you've got the external rotation in mid elevation, then you've got your middle glenohumeral ligament, and then external rotation in abduction. Again, so this is a good test to do, whether someone can rotate outwards or inwards in abduction, and we'll show you that on a video. And what that does is it shows you which sort of capsular structures have been affected. Every so often you will be fooled into thinking someone hasn't got a frozen shoulder because their external rotation is absolutely fine or not as restricted. It said in the majority of patients, the external rotation will be restricted, but in some patients you'll find it's not restricted, but they've got restriction in other range of motion.
Yeah, and I think that leads us quite nicely into this sort of presentation. So Jaissal, just people will say, well, how long is it going to get me better? It's all well and good for us guys to diagnose a frozen shoulder, but then we've got to give them a timeline, or we've got to give them at least an estimated time of how long it takes. What's your presentations, or what's the kind of patients you've seen in clinic that come in, and then how do you go about having this tough discussion?
For sure. So people often fall into two boats. Some have been to physios in the past and not been satisfied with the care they received. I had a patient referred from Mr. Dattani who didn't even know about the 3 stages about frozen shoulder, just had some physio, some passive treatment, and saw no progress. And that's kind of not surprising at all. So it's about really understanding and really clear in your communication to your patient, in that roughly it could take around up to 18 months, but it could even take more as well. People who manage a conservatively could take up to 3.5 years in some people as well. So everyone's different. There are 3 key phases here. So first of which being freezing, second frozen, and then also thawing. So any patient I come in who's been diagnosed with a frozen or who I suspect has a frozen, I always show this diagram here, and it's a really nice and easy one for them to follow. And it kind of just illustrates kind of the changes in their range of movement as their condition progresses, but then also kind of the pain that they may feel as well. So it's a really nice one just to summarize. And patients, don't take everything from your consult. If they can take around 5 things, this is definitely something that I'd assure that they understand fully, and then also understand kind of the implications for their long-term rehab.
So is there a quick fix? This is the next question that we get asked, is that what's the quickest way to get it back?
I wish I'm not that good with physio, but if there were to be a fix, it is a long process, but it's something that requires that kind of multidisciplinary approach as well. So liaising with someone like Mr. Dattani, who can give you the best evidence-based practice, going back to GP if pain relief is something after, but then also from the physio's point of view as well, given that kind of holistic, individualized care as well. It's, I think, why people go wrong is it's kind of just looking up on Google frozen shoulder protocol and how to rehab that, but that completely negates the individual there. You're just treating the frozen shoulder, but then you're completely ignoring the person in front of you who's potentially anxious, scared, not had sleep for the past 2 weeks because they can't lie on that side too. So there's no quick fix, unfortunately, but there is ways that we're going to show you that we can get through it and give you the best outcomes.
Yeah. I think this is a really nice slide. I always like sort of people taking photos, obviously. And if you have any questions, feel free to chat in the chat box. Just type something in. Jaissal or myself will be able to pick it up and then sort of, ask these questions live to myself, Rupen, or Jaissal. One of the most important things is pain relief. Rupen, what do you normally sort of see people actually benefit from in terms of pain relief? Because that's what they'll go to the GP for, right?
Yeah, absolutely. So it's a difficult condition, and I think in terms of even pain management, it's quite often said, you should try non-steroidal anti-inflammatories if there's no contraindication to them. The jury's out there whether it actually helps or not for frozen shoulder, but you're quite limited. Otherwise, you've got some codeine-based analgesia and maybe a combination of the two. It's quite often it's difficult. If they're finding it's difficult to sleep at night, often we'll say maybe have a pillow under your arm, because quite often it's rolling on one side that causes the pain. But often there isn't really an easy way to treat this. Quite often people find they're okay during the daytime because I think they've got their adrenaline and everyday work, but it's at nighttime it really keeps them up. But yeah, quite often I think anti-inflammatories is usually, if there's no contraindication, a good start for that.
Yeah, I think one of the things obviously we've found is that do nothing, the supervised neglect. Jason, I know you're quite passionate about this. Do you want to have a chat about it?
Yeah, of course. I think where people go wrong is that it's kind of just left, and then that leads to long-term consequences, like, for example, long-term disability, onset of chronic pain as well. It's kind of that there's a difference between active management and inactive management as well, and it's about being proactive with the rehab, taking the priority to have the shoulder seen to, and best manage as well. You're just leaving the door wide open for long-term and potentially more severe consequences if just left and just neglected.
Yeah, I think we've got a couple of questions, so let's just take a few questions. If you improve the length around the joint, should that be enough? So I think this is someone who's asked us on Facebook, if we improve the length of the joint, I'm guessing it's probably, if you basically stretched, or what we would come under MUA, would that be enough? So essentially someone asking if they can pull the shoulder out of the socket and create that space, whether it's through a release, which is going in there with a knife, the arthroscopy, or even just a manipulation anesthetic. Ruben, how many do you do MUAs? Like, how many MUAs would you say you would be doing, particularly for frozen shoulders?
So it's interesting. I don't do any MUAs. Having said that, I did lots of MUAs during my training, and the vogue sort of changed to go from MUAs towards arthroscopic releases. And the reason for doing that was, there are some potential complications associated with MUAs. So if you don't do them in a correct manner, you could potentially fracture the humerus. So it's got to be done in a very sort of, you have a short lever arm, and there's a particular maneuver you sort of tend to do them in. And there's also people where they did studies where they did an MUA and then subsequently put an arthroscope in, and they found there was damage to lots of structures, like you could get a labral tear, you could potentially tear the rotator cuff. And so there was quite a vogue moving away from it. But having said that, an MUA done correctly is an excellent procedure. It's very cost effective, and it sort of quite quickly improves quality of life. But it's one of those things where there's been a gradual vogue away from it. But if it's done correctly, it works really, really well.
Yeah, and I think one of the most important things, obviously, the physiotherapy and the steroid injection, with or without the steroid injection. But we're going to move on to obviously hydrodilation. But there was a question about the research around the NSAIDs and the anti-inflammatory response to frozen shoulders. It's a bit of a hit and miss. I think there's just not enough data to kind of like say, yes, it's definitely inflammatory and it's definitely this. But we know that NSAIDs, a lot of my patients will come back and say, well, I've had naproxen and actually that's helped me sleep better. And if they can sleep better, they're moving better, even if it's a sort of a short-term use. So it's a bit of a catch-22 where, we can't say one thing doesn't work, but one of the things we say is don't just rely on painkillers to take you through this, trying to get an active involvement in this. So supervised neglect, I think one of the things that Jason spoke about was that 50% of the time, people can have things up to 10 years. And then this study done showed that, people have this chronic disability. So as healthcare professionals, one of the most important things we need to do is move people away from that chronic disability. And something as, it might seem as simple as shoulder pain can be quite debilitating for a lot of people. So what do we do in physio? So a lot of those times with physio, it's basically a lot to do with the rotator cuff strength work, the global strength work, the deconditioned, sort of improving just the whole shoulder in itself in terms of like what we can improve range of movement, the capacity. So simple things like being able to pick a kettle, being able to sort of reach for something. These are simple things you and I take to granted, but patients really struggle with this. Now, manual therapy, and I know there's a lot of physios who've also joined this, and they might be questioning whether manual therapy is any good for frozen shoulders. Every frozen shoulder patient that I've seen, as soon as I put my hand on them and be able to just help them feel better, even for a short amount of time, they buy into the process. And that's what it is there for. It's there to be able to help people feel slightly better, help with the pain relief if there is any effect of it, and then be able to have discussions about how long it's going to take, how we're going to focus on strength work, how we're going to be positive about it, and how we're going to sort of address things. Jaissal, you have some really interesting patients right now who are anxious, who are uncertain about the future and the treatment. And you found a study that also looked at the psychological impact of this frozen shoulder. Tell me more about it.
For sure. Like I alluded to before, you're not treating the frozen shoulder, you're treating person A or person B who sat in front of you, potentially not slept for a few days. This particular study looks at kind of the quality of life and the impact in which frozen shoulder has. So like Rush said, the common signs and symptoms you look for is difficulty brushing your hair, difficulty putting on bra, something like you said, something so simple that we take for granted. But what they found is that there's certain themes that were categorized by the patient's responses. And it's kind of the pain that's there, which is often very severe, especially in the acute phases. But then also they can't explain it. And also they can't explain where it came from, whether it was, for example, a fall on the shoulder, there's a clear question and answer. But with frozen shoulder, something that's insidious. But then also that increasing level of disability and that frustration with the decreasing levels of range of movement often leads to kind of confusion, anxiety, especially around kind of delays in diagnosis. Like you said, something that we're constantly evolving our knowledge on. And then also uncertainty about future as well, whether it comes to work, hobbies, whether they're overhead sports or whatever, whether it's tennis, badminton, but then also in terms of any cost implications as well about further treatment too. So as healthcare professionals, it's our duty of care to ensure that we tackle each of these, as well as kind of the exercise side of things as well. It's a whole body approach rather than just looking at the shoulder, treating the shoulder.
Yeah, I think it's very important to kind of keep this approach, and not just for healthcare professionals, but also people and themselves. And I think it's one of the things we pride ourselves on. We ask deeper questions. You know, how is this really affecting you? And you know, someone could be like, well, I can't pick up my grandchild. You know, that to me is a problem that needs to be worked upon. It's very easy to just get focused in, here's your range of movement, you've got 10 degrees more than last week. You know, it's more about the deeper questions like, oh, were you able to do this week? And that's what physios need to sort of, you know, get moving towards. Rupen, this is a really good paper that you brought, sort of talking about the stages 2 and 3 of frozen shoulder. Do you want to highlight more?
Yeah, so, you know, I think when patients consult their GPs or the therapists, you know, the question is, does physiotherapy help? And I think it does help. Again, this paper, which is a systematic review, did show that it does help. And what it tends to do is, obviously it helps maintain the movements they have. Because sometimes people also ask me, or should I just have my arm in a sling? Should I not move it? And I said, no, that's the worst thing you can do. You want to maintain whatever motion you have. And, you know, you may not get necessarily a dramatic improvement in your movements until you sort of get into stage 3. I think it's certainly in stage 3, there's a good argument for doing physiotherapy to try and get them to stretch their capsule. In stage 2, sometimes, you know, patients find that the exercises are a bit too painful, that they're prescribed unless they've got adequate painkillers on board. And this is where we talk about, you know, we're going to come on to the effects of a steroid injection, or more importantly, a hydrodilitation in stage 2, followed by the course of physiotherapy.
Absolutely. I think, again, you know, research that's out there right now is obviously talking about the sort of FROST trial. This is very interesting because it was obviously looking at different things. Obviously, this trial did not include any hydrodilitation, but it's really important to see the fact that, you know, you had early structured physio, mobilizing techniques, a gradual home-based program, and then obviously a steroid injection. And you know, they found that actually a lot of this research was, you know, we've tried all different things and they've tried everything. And this was a really good paper. I think it came out in, was it last year sometime?
Yeah, so this came out in November 2020, so it's only in the last 3 months. It was in the Lancet. It's a British trial. It's the biggest trial of its kind produced anywhere in the world. And what they had is they had 3 arms. They had people who had physiotherapy, but a lot of those patients who had physiotherapy also had a steroid injection. than some patients who had surgery either in the form of an MUA or an arthroscopic capsular release. And what they looked at was various parameters, mainly the Oxford Shoulder Score. And what they found at 12 months was there's no difference in the three groups. The capsular release obviously was the most expensive and had some complications associated with it. But I think, one of the things is you may not have had enough numbers in there. So there was a trend that the people who had surgery would potentially get better quicker. But sometimes with these trials, you don't have sufficient numbers to prove that. But the overall take-home message was there's no difference between the three groups. But like you said, it didn't include a hydrodilitation in this, because when they initially set out to do the trial, you do your preliminary work, and at that point, when they'd surveyed shoulder surgeons and said, what methods do you use to treat frozen shoulders? And most people said they use physiotherapy, MUA, or capsular release, and that's why the trial was based on these three. But then hydrodilation became more popular, but they couldn't then have a fourth arm to this. So there are trials going on at the moment looking at hydrodilatations, whether that helps.
Yeah,
I think super importantly as well, all three arms of the study all included physio as well, whether it early structured physio, but then also post-operative as well. So just showing how important that effective management is there as well.
Absolutely. This is a really great paper that I've sort of found that it's obviously a meta-analysis. Again, another really good one. Rupen, do you want to sort of highlight the importance of the hydrodilation procedure now that you've got a paper that's actually sort of, looking at the conservative management for a frozen shoulder?
Yeah, so this paper, it was only actually published last month, and what they've done is they looked at all the systematic analysis and then formed a meta-analysis. And what that does is that the capsular distension that you get with the hydrodilation associated with corticosteroids. So what's injected in the hydrodilation is predominantly small dose steroid with some local anesthetic and saline, and you try to aim to get anything between 15 to 25 mils, depending on how tight the capsule is. And what they found is that provides a significant improvement in pain relief, both the short term, and then that improvement is maintained. So this is my preferred option of treating frozen shoulders. And almost most of my patients, I'd say 90% of my patients get treated in this manner. This followed by a course of physiotherapy.
Yeah. So we had like around 6 or 7 people that have questioned the use of steroid during the COVID-19 pandemic. Obviously, with everything going on, they're questioning, is it safe for me to use steroid injections? And the overall answer is yes. But is this something that you're getting asked quite often, Rupen?
Yeah, absolutely. So last year, when with the onset of the pandemic last March, the British Orthopaedic Association, British Rheumatological Association, British Association of Radiologists, Pain Management, they all categorically said you should not use steroid injections. And the rationale for that was, if you look at the evidence, so this is a paper that we wrote, looking back at the evidence, why were all these guidelines stating not to have a steroid injection? And it all stems back from 2003, where there was a SARS outbreak. And what they found is in SARS outbreak, people who were in intensive care who received steroids had a poor outcome. So this is completely, so extrapolated data from there to saying steroid injections should not be used. But now, if you look at it in terms of the recovery trial that was formed in the UK, actually dexamethasone is one of the treatment options for COVID. There was a paper that recently come out showing, I think 500 patients who've had steroid injections for various conditions. None of them went on to get COVID, right? So steroid injections per se are safe, I would say. Yeah. The only time you may want to be cautious is if you've got an immunocompromised patient, who's on immunosuppressants, have had a kidney transplant or whatever, or on strong immunosuppressants. You may want to then avoid steroids in that particular group, but that would be the case anyway. Yeah. But overall, I say steroids are safe, bearing in mind, there is that. What will happen is whenever patients get sent for steroid injections, the hospitals or the physicians or the radiologists performing it are obliged to tell them that there is a small risk of immunosuppression. And this is because the guidance hadn't changed. But quite often when I get asked this, I'd say I personally would have a steroid during the pandemic, because I think it's safe, and I've looked at the evidence. And this paper is online, and it's you can have a look at the evidence. That we analyze the evidence suggesting not to have it, and at the end our conclusion was we think it's safe.
Yeah, absolutely. And then I think the next question is obviously about COVID-19 vaccinations and steroid injections. Now, I think I've had 17 patients who've gone for the vaccine, but they're keen to have these injections as well. What is your approach with this? And I think there's a bit of a guideline that's just been released literally at the end of January.
Yeah, so again, very similar. So, if someone's about to have a vaccine and a steroid, I'll say withhold the steroid, have the vaccine. Similarly, if you've had a steroid injection, you should wait for at least 2 weeks before you have the vaccine, and vice versa. If you have the vaccine, don't have the injection for at least another 2 weeks. So, especially if people have already had one dose and are waiting for the second, or they're waiting their first dose, as long as if you've got a date for your vaccine, then try not to have your steroid within 2 weeks. But otherwise, it's absolutely fine.
Brilliant. So this is a really good presentation. I'll let
history, right? So you just told me earlier you've had this pain in your shoulder, that left, you're right-handed, yeah, and you have a desk-based job, don't you?
Yes.
Yeah.
Well, yes.
Yeah, and you fell
I did.
in January. Tell me just what happened.
30th of January, I had an accident.
So you remember it well?
Slipped, yeah.
Yeah.
Spiral fracture on my leg. My arm went back as far as my arm went back. I fell on my arm.
Yeah.
And I just thought it was bruised. But over a period of time, it turned out that it was not a bruise. It was damage to this area.
Yeah.
I've had physio. Hasn't done anything.
Okay. What have they done in the physio? Just tell me again.
I have to stand there and do this.
I'm going to pause it there just because if the physio's basically explained to someone, to a patient, what the exercises are, and they don't recollect it, we've definitely got to change it up. So I'm gonna take it back again. I think there's someone who is not muted their mic, which is coming out now.
I've had physio. Hasn't done anything.
Okay. What have they done in the physio? Just tell me again.
I have to stand there and do this. Can't remember.
Some of the exercises. No, it's not.
Yes.
Okay.
It hasn't worked anyway.
All right. And the pain severe?
Yeah, it keeps me up at night. It
Keeps
wakes me up.
Wakes you up at night. Can you lie on that shoulder at night?
I can, but not for long.
Okay.
This is my dominant side.
Yes.
And I tend to, in my sleep, roll over and sleep. And that's what wakes me up.
Okay. What about things like dressing? Are they difficult?
I can't do my bra up. Can't put a necklace on. Putting my hair up and the clip is even shaking me off.
Good.
No, I can't get my arm up.
Great. And your health is good? Otherwise, you're on any medication?
My health is fine.
You're fine. Any do any hobbies, any sports, do anything like that?
I used to be very fit. I put on X amount of weight because of my leg and my arm. I haven't been able to go to the gym, cycle, swim.
Can't do anything. All right.
Hence why I'm.
Just step forward for it. It's good. So,
what has anybody said to you was wrong with your shoulders today? It's like obviously you've been through a bit of a pathway.
Yeah,
from start to end.
Okay, I've had a ultrasound, and ultrasound then went on to MRI. They found a tiny little rip in the muscle. I've since been told that I have a frozen shoulder due to the injury, and that's it. Obviously, the physio, it's just not working. Okay. So hopefully this injection works.
Right, so just very quick examination, right? So just face the audience. So what I tend to do is from here, again, I normally do a quick cervical spine, make sure it's all fine. Just examine the shoulders. It looks like normal contours, there's no wasting. Looking from the back, it looks like, there's no wasting at all, right? So just let me know, is this sore on this side?
No.
Sorry.
No, that's fine. No.
No pain there?
No, when you press it.
That's sore, yeah?
Yeah.
And nothing there?
That's fine.
So that's the anterior joint line. So one study showed that if you press on the coracoid in a frozen shoulder, it's almost 100% relevance with frozen shoulder. When you see something less than 100%, you've got to doubt that. Nothing's 100%, right? So let's have a look. right? So it's quite marked external rotation. So this is one thing I do passively, because actively people sometimes do all this kind of stuff and it's quite difficult to examine, but quite clearly if you see that abduction on this side is pretty good, right? Almost 90 degrees. It won't go anymore, right? Now, if you elevate, go up on the side, pretty good, and do the other side. And then, and the whole scapula is moving, right? In abduction, if you abduct, if you go this way, pretty good. And this way. That's it. And then now, if you go up, the whole scapula is moving, right? The other thing I always tend to do is in abduction, you can externally rotate, internally rotate. Pretty good, right?
No.
There's nothing there. You see that? It's very, very short. So I think this is a post-traumatic frozen shoulder. So she's had an MRI and she's done an ultrasound, which both shown that the rotator cuff's intact. So as I said, when you've had an injury, you've got to rule out a rotator cuff tear. A hydrodistension will not work if you've got a rotator cuff tear because the fluid will just escape from the joint into the subacromial space. All right. So if you've got a rotator cuff tear, you can't do a hydrodistension because the fluid that's introduced into the glenohumeral joint will just escape through that defect, that hole that you have into subacromial space. You won't be able to, you won't know. Well, with a partial tear, you can do it. Well, a full tear won't heal, see, so then it just won't work. With a partial tear, if it's interstitial stairs, then I think you're fine. You still get the volume in. But with a full tear, it just won't. If it's a full tear, then you're almost certainly looking at either telling the patient just let it get better, or you're looking at surgery. If you're looking at surgery, which we're not going down the route of, it's just some people do it as two-stage, because when you do a capsular release, you want them to move straight away. When you do a rotator cuff, you want to slow them down. So there's a conflict. So either you can do it all in one go, you release them and then repair it and then put them in a sling, but there is a risk of it re-stiffening, or you do the capsular release, get the movements back. 6 to 8 weeks later, when the movements are reasonably good, you go back and do a cuff repair, putting into two general anesthetics. Are you okay? These are all arthroscopic, yeah, absolutely. All right, okay. So what happened is when she came to see me, she had an ultrasound, which showed a query partial tear. So I got an X-ray first thing, because that's the easiest thing I can get done in clinic, which showed there was no arthritis, and there was no fracture. Then she had an MRI just to make sure that the tear wasn't a full thickness tear. And then we're at this stage now. Yeah. Normally, it's the other way around. What we do is I'll get an X-ray, then I'll send them straight for an ultrasound plus a hydrodistension. So the ultrasound, if they find a full thickness tear, they'll send the patient back saying, sorry, there's full thickness tear, we couldn't do the hydrodistension. If they say there's no tear, they'll go ahead and do the hydrodistension. It's like a one-stop thing. So you're not getting patients going back and forth. So we always do plus and minus. So that's where we work with the radiologist that we know we can trust, and that we work together.
So it's the same way as we were trying to assess the experience from Australia. That's a window head. That's basically the glenohumeral joints. And you come in with a needle in the glenohumeral joint, correspond to the glenohumeral the humeral head articular cartilage, and then inject some local anesthetic first. You can see sometimes you would have doubts whether you're in the correct place or not. So that with ultrasound, you can see the needle is within the joint, but finding it so hard to inject.
So it's just because it's such a tight capsule. So quite often, a second procedure is required. If it's because then you can get more volume in next time around.
So it's a certain amount of volume that you're after.
So first time around, I think we were talking about earlier. Initially, when hydrodilitation became popular, people thought it was all about volume, just try and and then patients found that quite uncomfortable. And now I think we're trying to get about 15, 20 mils in to whatever patients tolerate. Sometimes they can't tolerate it anymore, and then they come back.
Stages.
Yeah, and when they come back the second time, they get a bit more in.
How soon the second time?
So what I tend to do is I see them around 4 weeks after this one. So she's going to have some physio after this. I see them 4 weeks, because sometimes you don't see the effects for about 2 weeks for the hydrodistension. So 4 weeks is enough time for me to know, and if not, then they'll have a second and see them 4 weeks after, if need be a third. Okay. So, and it's variable. What we don't know is we're not good at predicting which patients are going to do well with one, which are going to need two, which is going to need three. So
now, since I've injected some, now I'm finding it easier.
You can see how it's easier already, right? So the capsule's distended. And just tell me, how was it? Is it?
Putting a lot of pressure on my arm.
You're putting on the pressure, so you're feeling the pressure, yeah?
Yeah,
Good. Okay. Was it very painful when you had it done?
that's hurting me now.
Yeah. So it's just
Sometimes because it's pushed.
it's just pushed a lot of fluid in there, into
Can I
the
put
space.
some more, or
Can you tolerate it anymore?
You can, yeah, yeah.
No, just see what you
it
feel.
would be useful, but I don't
Can I,
want to
can I just move my arm a bit?
try not to, because there's a needle in the joint.
Oh, okay. Okay. Okay.
So we injected initially was steroid.
So, yeah, steroid and local anesthetic, so longer-acting lidobuficocaine. And after that,
Are you putting more in, are you?
saline, yeah.
This is just saline, it's just water, sterile water.
Feel that?
The needle is out.
Yes, that's all done.
It's one of the most painful.
Yeah. So so it just shows you that when we do send patients, it's not a painless procedure, but everything's so tight. There's no way it's going to be painless, right? So you do warn them about this, and we warn them in clinic. They're warned by the radiologist that he will be sore.
Normally, sorry, I have managed to inject approximately 25-30 mils altogether. Okay.
Can I ask a question?
Of course.
How much were you expecting to put in?
Yeah, about that much.
About that.
Yeah, okay.
That's good. So you got the right.
Now, how long will this pain last?
I wasn't thinking that I would be able to put this much when I was trying to inject the steroids.
Right, okay.
I was finding it absolutely very, very difficult to inject. But once the first injection went in, the capsule became slightly easier to get into, and then we managed to inject some more.
Okay.
Normally, after the procedure, it's a painful procedure. They would still be sore after the procedure, but sometimes when they start to dress out, they would say, "Oh, I'm already finding it easier to move my shoulder because there's lots of fluid in there." So,
Something it varies.
The drugs haven't worked yet. For sure. It's just because the fluid is there. Yes, it's there.
How do you feel, right? Do you have to help? Yeah.
It's too high up. Let me bring it down.
Great. So that was a great demonstration, obviously, of an injection. And, we had Rupen, obviously, working with one of his patients. And you could see the whole procedure. And it's obviously painful. And you have to sort of let patients know. But this is one of my patients, and she's great. So she's 4 days after a second injection. And this is where we've got to. And she was surprised at how much strength she was actually retained, and how much movement she got back after the second injection. You can see we're doing a lot of eccentric loading. So this is where we're strengthening the shoulder, by doing the appropriate strength work and working to really sort of push the shoulder. There's no point making them work hard, but making them do all the stuff, which is with Rupen, but not carry on with intense physio thereafter. So she gets a combination of hands-on and in the gym, strengthening her muscles, post-injection. I think we've got a fair amount of questions, so I'll leave this slide here. But to get in touch, we're actually going to be emailing you out Mr. Dattani's details, my details, and Jaisal's details. Jaisal, do you want to start off with a chat box? Maybe you can read out the questions.
Sure. So first question I had is from Martin. He said, "It's a really insightful. Thank you. I'm suffering with a frozen shoulder ATM and wondered what advice you have on sleeping positions as both my shoulders are painful. I'll open up the floor to Rush.
Yeah.
Mr. Dattani.
So I think pillows. I love using 2 or 3 pillows. If you have to kick your partner out of the bed, send them to the kids' rooms and you take the bed. Basically, priority is your sleep, because if you're sleeping, you're healing. And yeah, try and really put pillows. So one of the ways I like getting sort of pillows is if you can keep it sort of in front of you and supported. So if you imagine you're lying on your side with 2 or 3 pillows stacked up with the arm in this position. The other way to do it is underneath your armpit. You know, find what works for you. There's no right or wrong thing. And don't go buying these fancy pillows that they sort of sell on Amazon and stuff. You just need a basic pillow that works. We'll go on to the next one. And I think we touched there on it. They were showed on biopsy that there was no inflammatory markers found. Has that changed? I think the research is hotly debated here. So we're looking to kind of keep expanding our knowledge on this one. Evidence for Shockwave working on frozen shoulder. Believe it or not, I've actually found that I would see some change in pain versus movement. So I found that I can actually reduce some pain using extracorporeal shockwave therapy. So for those listening in, shockwave is basically where you put a sound wave through the tendon or the structure. And the one that we would use in this particular moment is known as a focused shockwave, which goes much more deeper. And actually there is definitely some research coming out showing it. We've also got in our London clinic Magnetolith, and this is a magnetic sort of a machine essentially generating these EMTT waves, which basically have helped some patients, especially with the pain side of things. Rupen, have you seen much sort of stuff about frozen shoulders and shockwave itself?
Not about frozen shoulder and shockwave, but I can imagine the theory would be very similar, right? You're trying to get very inflamed tissue. I mean, the mechanism by which shockwave works is sort of hotly debated at the moment, but it's, you know, we think that it may cause angiogenesis, you know, increase blood flow to that particular area. I think if it can be tolerated, I'm sure it probably would help for pain, and it's, you know, very non-invasive, so it's definitely worth a try.
Yeah, actually, focused shockwave is there's no pain at all. So the focused one, the radial, there is some pain because of the way the machine works. We've talked about frozen shoulder, and we've talked about early freezing stage, going into the frozen shoulder being the most painful stages. Is this the acute stage where we should use the steroid injection for a patient, Rupen?
Absolutely. I think that's where the frozen, you know, I think the steroid injection is going to be the most beneficial. If you think someone's going from the freezing to the frozen stage, A, it's going to be great for pain relief, and B, you may actually even prevent some of the fibrosis. So, you know, they may not get the severity of the frozen shoulder. Certainly, I think if you can catch them at that stage. And again, you know, that's the mechanism by which, why does a hydrodilitation work? You know, people don't know. Is it the volume distension that's working, or is it the steroid injection that's going in the right place? It's probably a combination of the two. But again, you know, if you can get them in the freezing stage, it's a lot easier than when they're really frozen, because in the frozen stages, the outcomes can be unpredictable of steroid injection or hydrodilitation. But invariably, most people say the pain levels are a lot better after the hydrodilitation. You know, the movements can vary, but the pain levels are a lot better.
Sure. We had a question about the coracohumeral ligament thickness, but I think your video explained it. And, you know, when it measures large on an ultrasound, or you pinpoint it, you know, again, it's a hotly debated thing about the thickness of it. I do find that if there is a thickness, the likelihood is up. The likelihood of a frozen shoulder is higher. Anything different you found, Jaissal or Rupen, about the ultrasound and the thickness of the ligament itself?
So I think a lot of radiologists will say if the thickness is more than 2 to 3 millimeters, the coracohumeral ligament, then, you know, it's suggestive of a frozen shoulder. Sometimes you can also see hyperemia in the rotator intervals, again indicative of a frozen shoulder. You know, frozen shoulder at the end of the day is a clinical diagnosis, right? You need to do other investigations purely to rule out other concomitant pathologies. So with a frozen shoulder, you must have a normal X-ray. So if you're going to do one investigation, you must do an X-ray. It's a combination of clinical plus an X-ray ruling out a frozen shoulder. Now, if sometimes someone's had a trauma and you're not quite sure whether they've had a concomitant rotator cuff injury, then you might want to get an MRI or an ultrasound. Yeah. An MRI will rule out, like a rotator cuff tear or other pathologies. In my practice, what I tend to do is they get an X-ray, And if from the clinical diagnosis is a frozen shoulder, there's no real history of trauma, they go straight to a one-stop clinic where they have an ultrasound evaluation initially to make sure the rotator cuff's intact, and then they have the hydrodilation under ultrasound, just as we saw.
Yeah, right. And I think it's done on that same sort of time as well, because it just saves them, like you said, coming again and again for more interventions. So I think if steroid injections help to relieve pain, is a good idea to continue doing them on a long-term basis. Jaissal, any idea on the steroid injections and the long-term use of steroid injections in itself?
Exactly. I think Mr. Dattani went over it quite nicely as well, that if you, in this current climate as well, definitely do the injection there in terms of helping with the pain side of things. And it's not something that we want to encourage over the long time. Mr. Dattani, what were your thoughts again? Anything you want to reaffirm there?
Yeah, so I'm not a big fan of repeated injections. There are some practitioners who like giving low dose steroids, so they'll bring them for multiple 2 to 3 injections, and it's again a different philosophy. But in my practice, I don't do more than 3. It's not because there's quite often I get patients say, "Oh, can I only have 3 in a lifetime, or can I only have 3 in a year?" There's no research to show how many you can have. It's just that if steroids not working, then obviously you've got to think of a different tact of how to best manage your condition. And the other thing is, especially if you're going to have steroids around the bursa, I mean, this is a slightly different condition, but if you're having it around the bursa, you want to be careful of not causing tendon attrition and eventually thinning of the tendon and tendon tear. It's probably not going to be as much of a problem in the glenohumeral joint, but if 2 or 3 haven't worked, then I think you have to think of alternative methods to try and treat this.
Absolutely. I think obviously we're getting lots of questions here, but I think support available for tendonitis and bursitis, I think you just answered that. But when we look at how many weeks do we need to avoid after, I'm guessing it's not just corticosteroid, but it's the hydrodilitation procedure. So I actually saw someone 4th day after the 2nd injection, but I normally see them sort of probably in like sort of 3 or 4 days. I'll try and get them into the clinic, only to start sort of active assisted movements, try to get them to understand that now it's the movement time. The pain has been controlled, and it's just, again, reassuring the patient, reassuring the person in front of us that this is all part of a holistic picture, where it is, here's the injection, now you go home and deal with it. And that's not how we want to sort of get that client journey to go through. Differentiating between frozen shoulder, arthritic, and rotator cuff, I think it's an examination. The person in front of you, history, great history, imaging if required, but most importantly, history. And then there's the mechanism of injury, or how early this pain came on, how late it came on, everything else. The 3 treatment modalities in the FROST trial. So, Jaissal?
So one was a movement under anesthetic. The second was a arthroscopic capsular release, both of which had post-operative physio. And the third one was structured physio without any surgical intervention. Yeah.
Perfect. I think we've got a patient who's got a second steroid. It's been 10 days, still painful, difficult with certain movements. I know you're seeing Mr. Dattani, so we won't discuss any live cases on this webinar. But again, look, the reason of having a second or a third sometimes, it's not just a steroid injection. It's also to do with sort of helping your movement. So if you've not been looking at like sort of pain control, if you've not been looking at doing your exercises, or if you've not been looking at getting some physio involved, a lot of the times that's the sort of place I'll start. And then I'll sort of obviously have that review with Mr. Dattani. We've had a really good, one of our clients, I think, to round it off, and I know it's 8:03. So we've had 2 injections referred to by Mr. Dattani. It's made a massive difference. It's one of my favorite clients to see. She's got very little pain. The range of movement is improving a lot, and she would highly recommend. I'm sure I didn't put that I'm sure I'm not paying her as well. So, let's do that. I'm going to quickly check on Facebook whether we've got any questions, but I do feel like we've answered most of the questions here. Yes, we've answered. Can you tell when you push the syringe and how stuck down the capsule is from the resistance? That's one of a neurophysio actually asking a question. Great question, Dhiren. And I do believe you can, because there's a fight back, isn't there, almost, Rupen?
Yeah, so initially when the hydrodilitations were introduced, the rationale was to try and rupture the capsule, so they, patients would come back saying, "God, that was really, really painful." But the thought process has changed now. So what will happen is the radiologist will get a certain resistance, and like you saw in the video, they'll ask the patient, "Do you think you can tolerate more?" And sometimes they'll say no. But then what happens is when they go for a second hydrodistension, you get a bit more volume in. See, the normal volume of a glenohumeral joint is anything between 20 to 25 mils, and we think it's lowered quite significantly in a frozen shoulder. So
yeah,
it's more by each patient you get slightly different volumes in.
Yeah, great. That's us guys wrapped up. I'm sure we've run out of questions, which is always a first, especially for Rupen. Everyone wants to get him on the screen and asking questions. So we'll be sending our contact details, but anyone who wants to reach out to you, Rupen, where should they find you?
So online, I work as part of Total Orthopaedics, or my website's londonshoulderunit.com. All the videos are on there, and if you've got any questions, just email us through that.
Jaissal, what's the best way people can get in touch with you?
Through my work email, so just my name, Jaissal at r-d-physio.co.uk, or have a look on the website as well. And yeah, we're based at the Darwin Wellness Centre, the Northwood Club. We have access to our rooms and the amazing facilities there, which we've recently moved into. So that's the best way to get in touch with me.
Fantastic. We have a clinic in central London in Marylebone. We've got a clinic in Vauxhall, and we've got a clinic in Oakwood as well. For us, the patient comes first, and more than that, it's movement being the best medicine. So thank you all, and we shall see you on the next webinar soon enough.
Thanks, Rush.
Okay.
Bye.
So we can ask everyone to leave the meeting. That'd be great.